ladies and gentlemen. My name is John Crozier. I chair the National Trauma Committee of the Royal Australasian College of Surgeons, and we're gathered virtually for the Damian McMahon Trauma Paper Competition of 2020. From the outset, on behalf of us all, I'd like to acknowledge the traditional owners of the land, the respective lands on which we are meeting. For me, it's the Gadigal people of the Eora Nation. And on behalf of us all, pay my respects to elders past, present and emerging. We are a binational college. E Nga Mana, E Nga Reo, Tiana Koutu, Tina Koutu Katoa, Nao Mai Haire, Mai Ki Tenei Hui. And that means to the prestige, to the many voices present, greetings to you all. Welcome to today's gathering. The gathering is very much in the spirit of Damian McMahon, for whom this is named. And Damian would be most impressed with the way this is occurring. He was the living essence of adapting, improvising and overcoming adversity. His life extinguished far too early. Now, we greatly honour his memory with the conduct of this trauma paper competition. It wouldn't be possible, though, without some background support, and I do, on behalf of us all, want to acknowledge the Transport Accident Commission of Victoria and pay particular acknowledgement to Sam Cofield. There's been a consistent support from the National Critical Care and Trauma Response Centre, and again, it's Len Notaris, who for years has been a consistent funder and supporter of trauma activities, and Michelle Foster. I'd also give gratitude to those that are participating, both the presenters critically. There are large numbers of fellows who have registered for the virtual meeting, and we have significant professional input from assessors. We've got, and I particularly want to acknowledge Catherine Martin, who was a key convener of this activity. She sends her apologies at this stage attending a funeral. We have Jacques Balog, Jeremy Sue and Dito Weber who will be assessing. Just a few quick points. There will be CPD points available to all fellows that participate in the activity. Recording. The webinar is being recorded and will be on the college website. Now for the presenters, there will be 11 minutes allocated, 8 minutes for the presentation, 2 minutes of question time and a minute of transition. Prior to the 8-minute presentation, 1 minute before that, Lynn will ring a bell. Now, registrants and attendees do not have the capacity to speak during the webinar, but there is the opportunity to engage in questions on chat or leave observations in chat. At the end of the presentation, questions for the presenters will be taken from the judges. And those that have contributed questions in chat, the questions will be asked through one of the assessors. Attendees will all be able to view the session live. Now, a critical element of the competition is that it allows a small financial stipend for the winner, but also the opportunity to present an expectation of presentation at the Region 16 meeting, which virtually will occur later this year on the 20th to the 21st of November. It is scheduled in India. Australia is a participant, a key participant in the Oceania and the Region 16. So the opportunity is there for the winner today to participate. And there's a further expectation and a great opportunity to participate in the ATLS competition of the American College of Surgeons Committee on Trauma scientific meeting the following year in 2021. I want to acknowledge and pay special gratitude to Catherine Walsh. She's coordinated the technology If there are faults or glitches, the responsibility for those is with me. But again, we're so grateful, Catherine, for the coordination. What I'd like to do now, if I could, is invite our first speaker, Nima Yaftian, to prepare, unmute, select the video, and she's to address us now on surgical fixation of rib fractures, the 5-year single centre experience. Nima.
Hello, I'm Damian McMahon, and I'm going to be speaking about the surgical fixation of rib fractures, a 6-year single centre experience. So surgical fixation of rib fractures has been increasingly utilised internationally, and there's growing evidence of both short and long-term benefit. We reviewed the outcomes of surgical fixation of rib fractures at a single centre over 6 years. So the procedure using plates was first described by Siller in 1961, and there is increasing evidence that surgical stabilisation of rib fractures is a cost-effective intervention that's associated with reduced ICU time, reduced ventilation time, length of hospital stay, and pulmonary complications in patients with traumatic flail chests. At our centre, the indications for referral for consideration of surgical stabilisation of rib fractures are 3 or more displaced rib fractures, a flail segment, rib fractures with a sternal fracture, severe chest wall deformity, or potential visceral injury from fractures. Contraindications for surgery are acute myocardial infarction, severe traumatic brain injury, unstable spinal fracture, unstable pelvic fracture, or an empyema. So for our study, a retrospective review of all patients undergoing SSRF from January 2013 to December 2018 was conducted. Patients were identified via trauma registry and thoracic surgical database, and ethics was approved by our institution's research governance unit. There are a total of 2,517 presentations of major trauma with an AIS codable rib fracture. 136 of these patients underwent surgery, and median age of presentation was 52 years. Mean injury severity score was 27. Radiological flail chest was present in 66% of patients, and ICU was the preoperative location for the majority of the patients in 82%. Hospital mortality was 1.5%. Complications occurred in 23.5% of patients. There were 2 patients who underwent reoperation for bleeding, and there was 1 patient who underwent reoperation for device failure. Mean length of stay was 22 days, and discharge destinations were rehab in 50% of patients, home in 35%, and another healthcare facility in 15%. Looking at the trends in trauma presentations at our hospital over the past 20 years, the proportion of patients undergoing thoracic surgical intervention for trauma has remained unchanged. However, the number of presentations for trauma in blue and the number of thoracic trauma presentations in red has increased through the years. We have a post-operative chest x-ray of a patient who's undergone the procedure at our centre. In conclusion, surgical stabilisation of rib fractures has been increasingly utilised in thoracic trauma. It's associated with low hospital mortality, and whilst questions about efficacy still remain, we hope to address these in a future propensity score matched analysis. Thank you.
Thank you very much, Nima. I'm Joel Balog, trauma surgeon from Newcastle. Catherine, could you turn on my screen, please? I would like to ask a couple of questions. One is that some of your contraindication would be, for me, the indication to do this surgery, like significant brain injury, thoracic spine injury. I agree that the timing of the surgery is critical, but somebody has a severe brain injury is important for them to ventilate properly and able to sit up. And also thoracic spine injury, fixation of the spine itself doesn't give the benefit if you don't have a chest wall which is able to move. If you could comment on that. My other relatively minor suggestion that if you use injury severity score, the middle value should be presented in median, not mean. You used extensively median during your presentation for other variables, but the ISS by definition cannot be described with the mean properly because it just doesn't have standard distribution. And the third question, if you could comment on why is your study unique beyond what has been known or presented in the literature, and what's its contribution to our knowledge in this management of severe chest injuries? Thank you much.
In terms of your first comment, with intracranial injuries, I guess the caveat is that if we feel they're unsurvivable, or if it's significant intracranial injury that's going to cause significant morbidity, then that would exclude fixation of their ribs. In terms of the unstable spinal and pelvic fractures, they're only contraindication while they're unstable. So after spines and pelvises have been stabilized, then we normally would fix ribs. So it's only in the period that they're unstable. Addressing your second comment, I'll take that on board and I'll amend my ISS scoring to median in future. Thank you. And the third comment, in terms of what this adds to literature, in the current state, we are presenting a large series. I think we're one of the largest Australian series of it, and we're presenting, I guess, our experience with it. What I think will contribute much more to the literature will be the future directions of this in terms of looking at propensity score matched analyses, comparing patients who didn't have their ribs stabilized with those who did. I think that'll contribute a lot more to the literature in terms of their short and long-term outcomes.
John, is it okay if I ask a question?
Yep.
Yeah.
Jeremy, please.
Jeremy Shue, trauma surgeon from Sydney. Thank you for that presentation. Just I guess it's more a comment, I guess, just to help you in that next step. I think that there's a lot of unanswered questions that are currently being described within this space that I would recommend to you that you kind of need to include in some of the outcomes and variables that you measure. So some of the questions that we still want to know is like, when are these patients operated on? Like you sort of alluded to it in the contraindications, you know, and about the spine and things, but, you know, those are sorts of some of the important outcome measures that should be recorded. So for example, when were they operated on? How many of these patients in ICU were actually ventilated? Therefore, how long did they stay on the ventilator? Right, so you need a couple of these other things, you know, their pain scores, like what was the distribution of their pain scores, you know, what was their, you know, their pain score at the 2 week mark, you know, what was their return to functional activity. So there's a whole lot of outcome variables that you kind of need to record and measure before you can even do that propensity analysis. So I would just recommend to you that you have a look through some of the literature, and then you can work out sort of the questions that we all want to know. And I think I've seen also a question on the chat from Mary Langcake, and an important thing about the costs of the procedure, which is another kind of variable to look into. And that takes into account a lot of those things about the prostheses, as well as then return to function, loss of employment, etc. So, but well done. Good job.
Thank you.
Jolt?
very quick reflection, what Jeremy just mentioned, that before you embark on propensity analysis, that's a big exercise, very involved and lots of work. And if you look around and look at registered trials, there are many randomized trials currently presented and ongoing. So that methodology is inferior to the RCTs. So if you embark on that, you need to understand what is your cost benefit to do that work when we already have higher level of evidence. So if you have a large number of patients, you just need to formulate a very important research question, which is a niche currently in our, or gap in our knowledge. Thank you very much.
Thank you.
Nima, thank you. And on behalf of the institution you represent, job very, very well done. I'll ask you now to mute and close your video. And Catherine, Grant, if you'd prime your video and prepare to share screen. Catherine is going to talk about the comparison of airflow and fenestrated versus non-fenestrated tracheostomy tube. Catherine?
So good morning, everyone. I apologise, I'm not in a suit. I've unfortunately no longer working at the Royal Adelaide Hospital. I'm working across in Victoria, and as such have been called into work on the COVID ward today, which is not ideal, but that's okay. So my talk today is comparing the airflow in fenestrated versus non-fenestrated tracheostomy tubes using 3D printing for a bench model study. This was conducted at the Royal Adelaide Hospital in conjunction with the respiratory, trauma surgery and ENT departments last year. So just briefly, the indications for a tracheostomy tube. So we know that the incidence of tracheostomy in critically ill patients has grown recently. Tracheostomy tubes are used to relieve upper airway obstruction, administer positive pressure ventilation, provide a secure and patent airway, and assist in removal of airway secretions in an effort to wean mechanical ventilation. Fenestrated tubes have an opening in the posterior portion of the tube, which decreases airflow resistance in comparison to non-fenestrated tubes. They are used to wean ventilation, but mainly to facilitate phonation in patients who can't tolerate a speaking valve. Studies have compared complication rates between the two tracheostomy types, and it's accepted that fenestrated tubes have higher rates of granuloma formation and subcutaneous emphysema. However, there has not yet been adequate comparison of airflow and the work of breathing between the two tracheostomy types. So the aim of this study was to compare airflow in fenestrated and non-fenestrated tracheostomy tubes by creating an anatomically and structurally accurate model trachea using 3D printing. We think it's important to quantify and compare the resistance between the tracheostomy tubes, as it is known that increased resistance to airflow requires a greater effort of self-respiration or mechanical ventilation to maintain adequate oxygenation. The extent to which a tracheostomy tube creates resistance depends on its characteristics. These include diameter, including the contrasting diameter of the inner and outer cannulas, the length of the tracheostomy tube, curvature of the tube, materials used, and the rate and type of airflow delivered. So we use 3D modelling software and a printer to design and manufacture an anatomically accurate model of the trachea. This was our prototype. We based this on a 3D printed trachea that was used for cracothyroidotomy simulation by a group in Canada. The duoderm dressing was placed over the trachea here, and then incised between what would be the second and third tracheal rings with a 10-blade scalpel to stimulate tracheostomy. We use shyly uncuffed tracheostomy tubes, which are what are used at our institution, and tubes were corked for the study. So this is the trachea model utilised. We placed it in a box for support of the trachea and also to ensure blinding of the trachea type. The superior component up here attaches to the spirometry device, and the inferior component down here attached to a pneumotachymeter. For the fenestrated tracheostomy tube, we were able to look superior and inferiorly into the trachea model to confirm position of the fenestration against the posterior portion of the trachea. We then measured PEF and FVC through the trachea model with no tracheostomy, non-fenestrated and fenestrated tracheostomy tubes in situ at various airflow rates using this pneumotachymeter device and spirometry. Flow rates were altered by adjustment of the volume of air in this chamber, where the speed of advancement of this pneumotachymeter hand pump remained constant. So looking at the analysis of our PEF, at airflow 25 litres a minute, we found that the non-fenestrated tracheostomy tube had significantly higher PEF than both the native trachea and fenestrated tracheostomy tube. At airflow 50 litres a minute, there was no statistically significant difference in PEF. At 100 litres a minute, the native trachea had higher PEF than non-fenestrated and fenestrated tracheostomy tubes. And at airflow 150 litres a minute, there was no statistically significant difference, but again, it can be seen that the PEF was higher in the native trachea than in the trachea with tracheostomy tubes in situ. And again, despite no statistically significant difference, it can be seen here that in the fenestrated tracheostomy tube, the PEF was slightly higher than in the non-fenestrated tracheostomy. Looking at FVC, the results appear to be more consistent. The FVC is a surrogate for how much air is hitting the spirometer sensor. And we can see here that the FVC was significantly lower in the native trachea throughout compared to trachea with tracheostomy tubes in situ. This was unexpected in our analysis, as you would think for FVC should be higher, in fact, in native trachea versus a trachea with a tracheostomy tube in situ, where we would expect more turbulent airflow due to obstruction of the airflow because of the presence of the tracheostomy tube. I'll discuss this a little bit further in discussion. So, in summary, our results show that the PEF was higher in non-fenestrated tracheostomy at airflow 25 litres a minute, compared to the native trachea and fenestrated tracheostomy tubes. And PEF was also higher in the native airway at 100 litres a minute compared to both tracheostomy tube types. Given the variability in our PEF results and also minimal differences in the values of PEF, where the maximum difference was 300 mils a minute, we conclude that these results show no consistent clinically significant differences in PEF and hence airflow velocity between the native trachea as well as the fenestrated versus non-fenestrated tracheostomy tubes. The results of the FVC analysis appear to be more consistent, where FVC was significantly lower in the native trachea compared to non-fenestrated and fenestrated tracheostomy tubes, and significantly lower in non-fenestrated tracheostomy compared to the fenestrated tracheostomy at all airflow velocities as well. These results show an increased expiratory volume, essentially, with fenestrated tracheostomy tube compared to non-fenestrated, and increased expiratory volume with tracheostomy tube compared to the native airway. We hypothesize this may be due to loss of air into the dead space surrounding our trachea model, given we would expect the FVC to be lower with tracheostomy tubes in situ compared to the native trachea. There are multiple potential sources of error in this study. As previously touched on, we hypothesize there's leakage of air through this 3D model trachea, probably around the join of the pneumotachymeter and spirometry, as well as through the duoderm that was simulating kind of skin and fascia. This means these results of the FVC analysis probably are minimally reliable. And we hope to further examine this in the clinical trial. The advancement of the pneumotachymeter hand pump was timed to ensure consistency, but performed by a human, so there is potential for human error. We did repeat measurements 10 times and then results were averaged out, so we hope to minimise this error via this. This bench model study is being further examined by a clinical trial examining the airflow dynamics in fenestrated versus non-fenestrated tracheostomy tubes in ENT patients at the Royal Adelaide Hospital. So in conclusion, there is no consistent, statistically significant difference in airflow velocity between fenestrated and non-fenestrated tracheostomy tubes in this bench model study. The FVC was significantly lower in the native trachea compared to tracheostomy tubes, and significantly lower in non-fenestrated tracheostomy tubes compared to fenestrated tracheostomy tubes. However, as touched on, this is unexpected based on our clinical experience as well as previous trials, and we expect this is most likely due to leakage of air. We hope to really further examine this in the clinical trial that's being conducted at the Royal Adelaide Hospital currently. I can now open up to questions.
Catherine, thank you so very, very much. And I'd gently invite Jeremy, if you just unmute.
Yeah, thanks, Dr. Grant, for that presentation. I always really like sort of bench stuff when people come up with creative ways of studying a particular question that you might have. But I guess from a clinical aspect, and you alluded to this towards the end of your presentation, can you tell us all, like, what is the actual clinical relevance? What are you trying to answer, and what are you trying to change by studying this particular question about the tubes? Because what's the downside of increasing flow? Like, does it actually make a difference if you found a difference? Say, for example, that you required, 100 liters of, whatever flow through if the patient had a fenestrated tube versus, only 25, like if they had a non-fenestrated tube. Like, as in, what's that clinical difference, and what are you hoping to change for, like, say, for example, our trauma patients that that might need a tracheostomy?
Yeah.
So that's I guess the main question that I have for it.
Yeah, definitely. So we kind of recognise that in our institution, we're really not utilising fenestrated tracheostomy tubes at all anymore. Most of our patients have non-fenestrated tracheostomy tubes, and I think that this is because there's well-recognised increased complication rates in fenestrated compared to non-fenestrated tubes. So we tend to avoid them unless we, really want to get them fenating and think they're going to be using their tracheostomy tube for a very prolonged period of time and can't use a speaking valve. So we kind of thought about this and said, well, what could potentially be the advantage of a fenestrated tube? There was a study 20 years ago that used just plastic model tracheas, kind of back in the day before 3D printing existed, that did suggest that there were better airflow dynamics in a fenestrated tube and reduced resistance to airflow, which means that weaning off mechanical ventilation could potentially happen with more ease because you're requiring less kind of ventilatory pressures for that increased PEF or FVC value, which essentially means your respiratory mechanics are improved. So we thought maybe we're not using fenestrated tracheostomies as much as we should be, and maybe we should investigate this further in a bench study to see if we should be increasing our use of those tubes, if they are improving the airflow dynamics. So it's really to look at that, to look at our PEF and FVC values at set airflow velocities, to examine whether or not it may be easier to wean these patients off their mechanical ventilation and onto, their normal physiologic breathing by using one tube versus the other tube, above just kind of using one or the other because of phonation reasons.
Yeah. So that's actually really important, because that now brings the context of your study into a much clearer, sort of with a lot more clarity. So again, like I think that's really helped, but I would recommend to you, again, as you're working on this, to include that in your background and your hypothesis, because that actually then brings that sort of bench to clinical practice. You've got a clinical question, and so that's been really helpful. So it helps us understand that you're looking at the tubes and coming off the ventilator, right? And so maybe we should be all using fenestrated tubes. That's a great question, right? Otherwise, I look at it and go, okay, you're putting flow through. I think there was also a question from Dr. Langcake from St. George asking whether the model's been validated to accurately represent the dynamic nature of the trachea.
Yeah, so this model was based on a model that was used by the Canadian group for cricothyroidotomy, and they had it validated. So they constructed it. They were a group of emergency physicians who constructed the model using kind of 3 different 3D printing materials, essentially polyfilaments that are semi-flexible. And then they had it validated over there by looking at kind of respiratory mechanics, looking at things like the PEF, FVC, and spent a lot of time and money kind of constructing these dimensions. So it's been very convenient that they had done that previously, and we've been able to use their dimensions as well as use the materials that they used.
Right. We'll have to stop there, Catherine. Catherine, I'm very, very grateful. Again, we'll have to bring a line there. Please stay safe in your current role in the hospital today, and you're bringing South Australian dignity to Victoria, which is wonderful. I gently now invite Matthew McGuinness. If Matt, you'd prepare to unmute and throw forward your screen. And Matthew's going to address us on nail guns, not just an occupational hazard.
Good morning, everyone. Thank you for having me. Today I want to talk to you about nail gun injuries at Auckland City Hospital in New Zealand. Just a very quick background on nail guns. They're obviously commonly used in the construction industry, and there are 4 main types. There's pneumatic nail guns, which use compressed air, combustion nail guns, which have a gas canister in the back of the nail gun, electric nail guns, which have a motor, and power actuated nail guns, which essentially have a powder cartridge, and fire nail guns at the highest velocity. So the aim of this was to describe presentations of nail guns at Auckland City Hospital over a 25-year period. Data was collected from the Auckland City Hospital Trauma Registry database. We searched it with keywords nail and gun, and then we retrospectively reviewed patients' files for aspects relevant to their presentation. So very early on, we noticed 2 groups. So there was 45 patients in total, and there was 2 very distinct groups. 14 patients, so 31% of the cohort, presented with an intentional injury, a suicide attempt, and 31 patients, which was 69% of the patients, presented with an unintentional injury. Between these 2 groups, there was no difference in age, there was no difference in ethnicity, and all patients in this cohort were male. So looking at the patient and injury characteristics. So in the unintentional injury group, all these injuries happened on a work site. And in the intentional injury group, the majority, well, 35% happened at home and 28% happened on a work site. All the patients in the cohort were in the construction industry. So we were able to identify this in 41% of the patients, so in 41 patients, so 91% of the patients. And in 4 patients, we were unable to identify which industry they worked in. Again, there was a very different type of injury in these 2 cohorts. So in the intentional injury, 85% of these patients had a head injury, and all these nails pierced the skull and were intracranial. In the unintentional injury group, 80% of the injuries occurred to the extremities. So our primary outcomes, we looked at injury severity, length of stay, ICU admission, and mortality. So there was a significant difference in the median injury severity, with a very high injury severity in the intentional group of median of 25, and in the unintentional group a median of 1. Length of stay was also significantly different, with a median of 6.5 versus 1.2. And again, the ICU admission rate was very different. So 65% of the patients in the intentional injury group were admitted to ICU versus only 1 patient in the unintentional injury group. And that 1 patient had a cardiac injury, so a nail that went through the chest. Mortality was also very different. So there was only 3 deaths in the total cohort, and these were all in the intentional injury group. So that was a fatality rate of 21%. We also looked at admitting team operations and discharge destination. So the admitting team, as expected, was quite different, with 50% being admitted under neurosurgery and 35% under ICU in the intentional injury group, and the vast majority in the unintentional injury group under orthopedics, which fit with these extremity injuries. Operations, there was no difference between the two groups. So 78% of the patients in the intentional injury group had an operation, and 3 patients, so 21%, did not have an operation. These 3 patients were the patients who unfortunately succumbed to their injuries. In the unintentional injury group, 87% of patients required an operation. Discharge destination was also significantly different. So 100% of the patients in the unintentional injury group were able to be discharged directly home, versus only 21%, so 3 patients that could go directly home in the intentional injury group. 35% required transfer to another hospital. Most of the time this was a psychiatric unit. 21% required a rehab stay. So we looked at the rules regarding nail guns in New Zealand. And as I said before, powder actuated nail guns are the ones that can fire at the highest velocity. So these are often used for concrete and steel. These are the only nail guns that require a certificate for commercial use, but not for commercial use. There was no regulations pertaining to the purchase of nail guns, so there's no age restriction, and there's no regulations around the storage of nail guns. Thankfully, most nail guns do have an inbuilt safety feature, which means that you can only fire the nail gun when it's pressed hard against a surface. But there is no specific safety feature to stop nail guns being fired against the human body. So in conclusion, all patients in this cohort were male and worked in the construction industry. There were 2 distinct groups found. And in intentional injuries, these are always very severe, with 65% of patients requiring an ICU stay and a 21% mortality rate. There was minimal to no regulations governing nail guns. So going forward, we suggest consideration of further regulations for workplace and personal use, and specific safety features to prevent use against the human body. Thank you for listening. And is there any questions?
Matthew, thank you. I'll just gently now invite Dieter.
Lynn, if I can be put on the screen, please. My video. Thank you. Thank you, Matthew, for that presentation. I'd firstly like to congratulate you and your colleague authors on investigating a rare but important mechanism in a field where most of this evidence has come from very small case reports. This, on the other hand, now is offering a decent size experience and cohort. I've got several questions. I wonder if you can elaborate a bit on the trauma system in Auckland or in New Zealand to give us a bit more insight on the overall epidemiology here of this disease. And I also wonder if any efforts were made to perhaps get data from the coronial databases or whether this is purely based on the hospital registry. It would be interesting to get a bit more information there. Also, can you perhaps comment on any changes that you observed over time? This study was conducted over more than 25 years, and so I do wonder about what's changed in trauma systems and the management of neurotrauma. Also, perhaps a comment on any possible long-term follow-up with the patients. Finally, do you have any public health messages? Thank you.
Thank you. Thank you for the questions. So in terms of the epidemiology of this is, I guess, the very tip of the iceberg in terms of patients with this injury. Obviously, these are only patients that were actually admitted into hospital and therefore caught in our Auckland Hospital Trauma Registry. Auckland Hospital is one of 3 main metropolitan hospitals in Auckland and has a catchment area of about 600,000. There's also 2 other large hospitals in Auckland. So these 45 patients are actually, as I said, the tip of the iceberg, the only ones requiring an admission to hospital. And there'll be a significant amount of patients who will only come to the emergency department or the general practice who would not be captured in this at all. So that's a really interesting point, and I think possibly approaching the government for the ACC, which is the injury compensation claims, we could get the information for how many nail guns overall during this period, and that'd be an interesting comparison to see. In terms of going forward and health messages, I think approaching WorkSafe New Zealand, which is the governing body for workplace safety, would be important, especially with the high suicide rates in New Zealand and the significant mortality associated with a suicide attempt from a nail gun. So, there's, I think, certain things that could be done, including an age restriction on the actual sale of nail guns. There could be regulations around the storage of nail guns, so possibly at home and also on the work site. There's no regulations around that at the moment. And investigating safety features that would limit the ability to fire them on the body. And then education in general and suicide prevention in the workplace. Well, you'd have to quickly remind me what your other questions were.
We might have to draw a line there.
Thank you. Excellent.
And I'm again grateful for the significant body of work that you've brought forward for us all today, Matthew. So on behalf of us all, I do thank you for the quality of that presentation. And Dita, forgive me for cutting across. I wonder now if we can bring forward Jordan Hamilton, and Jordan is going to address us on VTE and trauma experience at a level 1 trauma service. Jordan.
Good morning. Jordan Hamilton, and this morning I'm speaking about VTE prophylaxis, a 10-year review of prescribing practices at our institution, which is the Royal Melbourne Hospital in Victoria. Sorry. So the background for this, I suppose, is fairly well known. Deep venous thrombosis and specifically pulmonary embolism are a leading cause of death for trauma patients who survive their initial injuries. And actual VTE incidence rates are reported variably from sort of 2 to 43%. And they're associated with an increased mortality rate, particularly with pulmonary embolus, as well as increased costs. Despite all this, though, the level of evidence for recommendations on prophylaxis is quite low. Large reviews on the topic have found some evidence that chemical prophylaxis is better than mechanical prophylaxis at preventing DVTs, and some prophylaxis is better than nothing. And similarly, there's some evidence that low molecular weight heparin is probably a bit better than unfractionated heparin just at preventing DVTs. Also a growing body of evidence to suggest that early initiation of chemoprophylaxis, even for patients with what would traditionally be considered a contraindication, like intracranial hemorrhage or spinal trauma, is safe. But the specific aim of this project was to determine the rates of VTE events for our institution, and then for these VTE cases, assess what prophylaxis, if any, was used, and also the influence of a risk assessment tool that was introduced in 2013. So this was a retrospective database review. Patients were identified using a trauma outcomes registry. We included all major trauma admissions within that time period who had a confirmed VTE event on either imaging or autopsy. And for these patients, we went on to do a drug chart and medical record review to assess prophylaxis complications, contraindications where they were documented. It's worth noting adequate prophylaxis was covered within the sort of 48 hours prior to diagnosis, which is a marker that's been used in these types of studies previously. So this is able to describe the which was a predominantly male, high proportion of blunt mechanism injuries with quite a long hospital stay and an in-hospital mortality rate of 8%. In terms of overall incidence, so 237 VTE events across over 7,400 trauma admissions. And as may be expected, the commonly associated injuries were rib fractures, long bone fractures, and intracranial hemorrhage. Regarding our compliance, VTE, interestingly actually, chemical prophylaxis was prescribed for 61.2% of patients, but only actually administered for 46%. And unfortunately, due to a lack of documentation, we weren't able to comment on mechanical prophylaxis usage rates as it's inconsistently documented, we found. And 129 patients did not receive chemical prophylaxis at all. These two graphs, the graph on the left shows our annual incidence of VTE events, and you can see that the blue line is the total incidence rate, which has traditionally been around about 3%, with a rise noted in the last 3 years, which appears to be driven by cases of PE and combined PE-DVT. The cause for this is not immediately obvious from a study such as this, whether there's increasing clinical suspicion and we're catching more as a potential answer, but it needs a bit more investigation. That contrasts to the graph on the right that shows the proportion of VTE cases that did and did not receive prophylaxis. And you can see the red line shows cases that did receive prophylaxis that's historically increased to be above 2.5% as it is now. Over 54% of patients didn't receive chemoprophylaxis, as you might expect in this group, and there was a documented contraindication for 43% of those, of which intracranial hemorrhage was the most common. But worth noting was 11.4% of patients didn't receive prophylaxis and did not have a contraindication found. So whether that's a prescribing failure or a documentation failure is difficult to know. Treatment, 184 patients were therapeutically anticoagulated, 25 prophylactically, and 21 received filters. The 15 patients that did not receive treatment were mostly mortalities, and there were 17 major bleeding events, and those were sort of fatal bleeds or critical bleeds into critical sites or bleeds causing hemodynamic instability, and as I mentioned, 19 in-hospital mortalities. The other part of this study was to have a look at our usage of a VTE risk assessment tool. So the Royal Melbourne introduced the box you see in the top right in 2013, a small assessment, and then a larger 3/4 page assessment tool in 2016. From this study, 143 patients were eligible to have a risk assessment completed, but only 49% actually had it. Chemical prophylaxis was administered at a higher rate where the risk screen was completed, 62.9% compared to 41% if not. But it is worth noting that in recent years, rates have been improving overall, which is probably due to the introduction of a larger screen and a pharmacy education campaign that came along in 2016. Ooh, sorry. The major limitation of a study like this is that to obtain medics, which sometimes, despite being very lengthy, don't always have the information we're after. Also, this likely underestimates VTE event rates, primarily because we've included symptomatic VTEs. There was actually a clinical trial running for a few years at the Royal Melbourne where trauma patients had twice weekly Doppler ultrasounds. So some asymptomatic DVTs are included, but this was certainly not consistent throughout the study period. And as previously mentioned, a lack of data relating to mechanical prophylaxis was disappointing. So in conclusion, overall VTE rate of 3.16 is acceptable and is in keeping with other centres of our size. And for patients who did suffer a VTE event, we saw a low chemoprophylaxis rate, as you might expect, with a high proportion of documented contraindications. And the rates of VTE risk assessment completion were low in this group, and that would be an interesting area for further research for the population to assess in prevention. And I think I'll open it up for questions.
Jordan, thank you. And the topic is of immediate relevance to large numbers of trauma centres around Australia. You did make the statement that a range of prescription was not associated then with the high administration rate that should have followed that prescription rate. Do you have an explanation for that disparity? Why did so many get it prescribed but then have the failure of administration of an appropriate chemothromboprophylactic agent?
Yeah, I mean, it is difficult to know. What we saw a lot of from medication chart review is often prophylaxis would have been prescribed, a patient would have had several doses, and then for a few days prior to the diagnosis of the VTE event, simply wasn't signed on the drug chart, and it wasn't correlated with a medical note saying, you know, concern relating to bleeding or now refractory intracranial pressures. So it's hard to know if there was a clinical indication for why that medication was withheld, or whether it's just a documentation failure.
Right, and if another question, if I could, you noted the upward trend, in particular the last 3 years of VTE. You also made reference to an increasing use of the screening tool. Do you know what the concordance of those two observations is? And do you think there is any relationship, or are there other explanations for that rising incidence and prevalence of VTE?
Yeah, it's I'm not sure from our data. There's good evidence from Westmead recently that a similar risk assessment tool decreased their rates of both fatal and non-fatal PE. But keep in mind, this population was only VTE cases. So I think to assess the impact of the screening tool, you'd need a broader population, including the patients who had their risk screen completed who did not develop a VTE event, to assess its sort of effectiveness on that outcome.
Excellent. All right, Jordan, again, I'm very grateful. I'd ask now if we can transition to Matisha Herath. Matisha is going to address us on managing renal trauma in the 21st century, a 15-year retrospective analysis of renal trauma in a tertiary South Australian referral centre. Matisha.
Morning all. My name is Matisha Herath. I'm a General Surgical Registrar at the Royal Adelaide Hospital at the moment. Thank you for this opportunity for allowing me to talk. So we have no conflicts of interest to declare, and this study was granted ethical approval by our local HREC. Bit of background about renal trauma. So as everyone's aware, trauma is the #1 cause of mortality among young people worldwide. Renal trauma itself is responsible for about 1 to 5% of all total injuries. In our centre, renal trauma is managed largely by the general surgical team, with 80% of patients being admitted under general surgery without any urological input required. Globally, the consensus in renal trauma is that the kidney, if avoidable, should not be touched, and conservative management and close observation is the best management. However, there are some indications for intervention, those being hemodynamic instability, expansile retroperitoneal hematoma seen during laparotomy, or PUJ disruption. Now, our study was a retrospective cross-sectional observation analysis conducted in all patients who had renal trauma between 2002 and 2017. We used ICD-10 codes to populate this database, and then coding errors and iatrogenic injury were excluded. We used our electronic health records to collect demographic data on age, gender, mechanism, length of stay, interventions, and complications. We had 2 reviewers examining all CT images on patients that fell within this cohort, and we used the American Association of Surgical Trauma to classify the injury. Now, we found that our cohort of patients had a reasonably high incidence of benign renal cystic disease, and we needed to expand further on the AST classification. So for our classification system, we took a single ruptured cyst as grade 2, multiple adjoining cysts that were ruptured grade 3. If there was any collecting system involvement, that was grade 4. And on definition of a shattered kidney, we took that to interpret as multiple lacerations involving all 3/3 of the parenchyma, or the parenchyma in multiple discontinuous fragments with no fragment being larger than half the kidney size. So our results, 15 years, we had 365 patients admitted to the Royal Adelaide with renal trauma. There was a 83% male predominance with a median age of 30. The vast majority of our patients sustained blunt trauma, with only a minority having had penetrating injury, which is consistent with our admissions across all cause traumas. So mechanisms: motor vehicle accident, motorbike accident, or road traffic accidents accounted for 59% of everything else. Falls and sports were the second most popular causes. Of those sports, AFL and cycling were the most likely culprits. Of the patients who had penetrating injuries, 17 of those were stabbings, and we only had one patient in 15 years with a gunshot wound that caused a renal injury. The grading of the injuries as follows. It's usually patients presenting with mild to moderate degrees of injury, and only 3% of patients had bilateral renal injury. In terms of other injuries, as can be expected with the high impact blunt force renal injury, the more blunt force mechanisms, there's a high percentage of patients that had associated rib fractures, other retroperitoneal injuries, splenic injury, liver injury, and pelvic fractures are also quite common. Now, for our cohort that had interventions, the number of laparotomies that were conducted in this cohort seemed quite high, but the majority of those were done for management of other injuries in the context of hemodynamic instability on arrival. In our 15 years, we only had 5 nephrectomies and 2 partial nephrectomies. Of those, 2 of the nephrectomies were primary and 3 of them were delayed. In that delayed cohort, 2 of them were following embolisation. One was for rebleeding after an embolisation, and another one was for persistent malignant hypertension, which was intractable to medical management and required a nephrectomy. Overall, there were only 82% of the patients were able to be managed without requiring any sort of operative intervention. And in a breakdown of 5 years sub-cohort analysis, we can see that there is an increasing trend of renal angiography being performed, and that's likely due to the availability of it, because the Royal Adelaide in particular had an increasing number of interventional radiologists available in an on-call interventional radiological roster. We can see, though, that the number of actual radiological interventions being performed hasn't changed significantly despite the number of angios increasing. So the take-home messages from here is that the majority of our trauma is blunt, and you can't trust Adelaide drivers. The majority of patients with renal trauma can be managed non-operatively, and we can see that there's an increased number of interventional radiological procedures being performed at our centre. Thank you.
Thank you very much, Matish, for your clear presentation of this well-documented study. I have several observations and then a couple of questions. Probably I say one observation, that you said that your study is describing something in the 21st century. I think it would be good to have in an Australia major trauma center in the 21st century, they actually document real-time the grade of renal injury. Which means that either a radiology report or verify that by the surgical team. So doing a large study and going back by 2 reviewers and grading in retrospect the renal injury is is done probably 50 years ago when the score was developed. The other thing, and if you would like to modify or classify something different, what you said that you had the cystic disease or whatever, you need to verify that, because the WAST score went through several modification and verification. You just cannot say that, okay, we gotta classify here now or this way. My specific question is that could you please state what was the aim and hypothesis of your study? I might have missed that. And the other one is, what are the results from your study which kind of unexpected or new to change practice? Thank you very much.
So thank you for your question. So the aim of our study was to examine our clinical practice in management of this disease and to see if we are conforming or we could improve our service compared with the global consensus of management. We theorised that we were performing and we wanted to also to examine to see how much of a role the availability of interventional radiology has changed our practice as well.
Thank you.
And just a quick question from chat, if I could, Mathisha. Were any delayed diagnoses or missed injuries?
There was one patient who was transferred from another hospital who was actually discharged with a grade 2 renal injury. That patient then presented hemodynamically unstable and was retrieved to the Royal Adelaide, and they underwent a angiography, but no brisk bleeding vessel was found. They were managed non-operatively after that.
Thank you. And it's, again, pleasing that the absence of penetrating injuries in this is a wonderful reflection, I think, on a much safer environment than is the case in many parts of the world. So, Mathisha, thank you so much for the presentation. I'd call now Patwinder Gill, who's going to address us on factors associated with short-term complications following pancreatic and duodenal trauma. Patwinder.
Hi, good evening. Thanks, Mr. Gauthier. I'm Dr. Patwinder Gill. I'm one of the general surgery registrars at Royal Melbourne Hospital, and I'll be presenting on the factors associated with short-term complications in pancreatic and duodenal trauma. There we go. So pancreatic and duodenal trauma, as you know, is uncommon, with a reported incidence of 0.2% of all trauma. It's associated with increased mortality and morbidity and is usually due to the delay in diagnosis. Over the last few decades, there has been a significant change in the management and the way trauma is managed in Australia. This study is aimed to analyse the management of pancreatic and duodenal trauma in the modern era, with a view of what contributes to the mortality and pancreatic and duodenal specific complications. A retrospective review of a prospective database was conducted over an 18-year period. All patients with pancreatic and duodenal trauma above the age of 16 was included in this study. Patients who underwent surgery at an external institution or passed away in the emergency department, or whom records were incompletely available were excluded from the study. Data was obtained on the patient demographics, severity of injury, management undertaken, and any complications that developed. These are the refresher for the grades of pancreatic and duodenal injury. We considered grade 1 and 2 injuries as low-grade injuries, while grade 3 to 5 injuries were classified as high-grade injuries. The outcomes measured was mortality as a primary outcome and pancreatic and duodenal specific complications as a secondary outcome. Statistical analysis was conducted via the Fisher exact test and Pearson chi-square test, with statistical significance classified as a p-value of less than 0.05. 52,420 patients were presented to Royal Melbourne Hospital in this 18-year period, 12,000 of whom were classified as major trauma patients, with 164 patients developing pancreatic or sustaining pancreatic endoduodenal trauma. This brought our incidence to 1.26%. 8 patients were excluded as they passed away in the emergency department, 4 excluded due to undergoing laparotomy externally to Royal Melbourne Hospital, and 4 were excluded as we were unable to obtain complete records on them. This left us with 148 patients in this study. There was a male predominance in the study with an increased incidence in pancreatic and duodenal trauma over each 6-year time frames. The majority of the patients sustained high ISS scores. Blunt injury was the predominant mechanism of injury involving motor vehicle accidents. The grade of injury was commonest with pancreatic injury, occurring more commonly, and low and high grade injuries distributed accordingly. The majority of patients, as you can see, required operative management, with most of these patients being able to be managed with definitive management of their pancreatic and duodenal injuries. The mortality rate was 11.5%, which was associated with shock requiring blood transfusion and grade 5 pancreatic injuries and the need for operative management. Pancreatic specific complications occurred in 37.2% of the population, and pancreatitis was the commonest complication noted, and this was associated with the need for damage control surgery. Pseudocysts occurred in patients with high-grade injuries, such as grade 3 and grade 4 pancreatic injuries. As you can see, grade 3 pancreatic injury was associated with the development of pancreatic fistula and pancreatic necrosis, and with patients requiring a longer stay in hospital with pancreatic necrosis. Duodenal complications occurred in 2.7% of the study population, with patients who experienced anastomotic leak requiring longer hospital stay and ICU stay. Duodenal stricture was associated with a grade 5 duodenal injury and the need for a gastrojejunostomy. In conclusion, mortality was associated with a high severity of injury and hemodynamic instability. Grade 3 pancreatic injuries occurred more in patients who required distal pancreatectomy, and they were more likely to develop a pancreatic specific complication, and simple management of duodenal injury is safe. There are several limitations to this study. First of all, this was a retrospectively performed study, and only major trauma was included. Though it would be surprising to classify any patients who've had pancreatic or duodenal trauma as other than major trauma. There was also a low volume of patients, but this is reflected in the low incidence of pancreatic and duodenal trauma. I'd like to acknowledge Dr. Daniel Maraskia and Dr. Annalise Coco for their help in this paper. Move on to questions.
Padwinder, thank you for the presentation. And Jeremy has a question or two for you.
Yep.
Yeah, thanks, Padwinder, for that presentation. It's an interesting area because it's quite uncommon, but does often require intervention. A couple of comments and then a question. I guess you've said it's modern era, but it's over 18 years. Me personally, I wouldn't call that the modern era. A lot of things have changed in 18 years in trauma management in terms of resuscitation, how we manage imaging and the like.
Yeah.
I guess the questions that I have is that how was the grading performed in terms of your classification of these injuries? What was low and high grade, like as in your definitions of low and high grade for those injuries? And it wasn't clear to me in terms of your complications, whether it was a relation, whether you were trying to relate it to the actual injury or the intervention, the specific intervention, like for example, how many distal pancreatectomies? Was it the fact that distal pancreatectomies were done in grade 3 and 4 injuries was a Whipple's done, the complications, and that's, I guess, part of what you'd hopefully do in a multivariate analysis by putting in all the potential variables that could influence the outcome. Because it's a great question, what results in the complications. So those are the, maybe you could let us know.
So I can elaborate on that. So the grading of the injuries were performed via the AAST classification system as well as the AIS scoring system. And this was based on the reported operation report findings and the imaging findings during the analysis or data retrieval process. And this uses the 2018 AAST classification criteria. With regards to the association between the grades of injuries, we did actually assess the grade of injury and the development of the complications, as well as the intervention that was performed for the various grades of injuries in all the patients who developed those specific complications. The data, I understand I presented very limited data, but the analysis, I only presented the statistical significant data selectively, but analysis was performed in the patients, say with the grade 3 pancreatic injuries who required a distal pancreatectomy. So there was an association with regards to grade 3 pancreatic injuries developing pancreatic fistulas and pancreatic pseudocysts, but was not associated with the development of pancreatic necrosis. For example, Whipple's procedure wasn't actually commonly performed in this study, with only about 4 patients in the whole study group that required a Whipple's procedure. And of this, only the patient who did require pancreatic or duodenectomy, the only complication they sustained was the anastomotic stricture in that one patient, in the duodenal anastomosis.
There has been a question from somebody in the audience. Again, were many of the diagnoses delayed or missed?
So we didn't actually have many patients that were misdiagnosis. We did have a few that did have delayed delayed diagnosis of pancreatic and duodenal injury. We did note that one patient there was a increased risk of developing pancreatic fistulas in patients who had delayed management of their pancreatic leaks. That again was identified late in their management. And there was noted a range of between 3 days of being diagnosed with a pancreatic injury, and even one patient actually being diagnosed up to 2 weeks later with a pancreatic injury and complicated by a pancreatic fistula.
Right, that's a comprehensive set of answers, Badwinder, and a good presentation. So thank you so very, very much.
Thank you very much.
Just at this stage, let people know before we break for a tea break, Dita Verba is going to address us on training opportunities within trauma in Australasia. Dita?
Thank you. Okay, I hope I'm projecting. I hope I don't take up everyone's morning tea time here. I'd like to thank the organising committee today for giving the PFET committee some airtime to advertise what we've been developing on over the past few years in establishing a post-fellowship training program or training pathway into trauma surgery. We have here on the slide the organisation that has collaborated together with us in ANZAST, General Surgeons Australia, to provide the administrative backing, the administrative support that we needed to initially establish this. But by no means is this intended as a general surgical pathway. Trauma has evolved over the past several decades, and it has evolved in all areas of the 9 fellowship streams that we have in our college. Trauma is in a unique position where it is represented by a trauma committee across the fellowship, orthopedics, vascular, ENT, neurosurgery, cardiothoracics. All these streams play a critical role in modern trauma care. So with that background, the committee here set up a collaborative pathway to develop a training stream, initially starting off with general surgery, but I hope that over the next few months we will also here on this screen be able to put up the logos of the New Zealand Association of General Surgeons, the AOA, the AOTS, and the vascular surgeons. The model that has been used is very much intended over the next years to also include trainees from those fields. Ultimately here, the goal is to have the RACS brand attached to the post-fellowship training program so that it is a formal accredited program. A similar program that this is also modeled on is of course a transplant program that also reaches the 9 streams. The objective of the program is simple. It's to train surgeons to a standard where we can be regarded as specialists in the care of the severely injured patients. We've been very deliberate there to include all surgeons, and the focus here is on the injured patient. How does this translate? What do we want to see out of this? We want to see a clinician that is able to receive and resuscitate a severely injured patient and perform those initial time-critical resuscitative surgical strategies, surgical maneuvers that are inherent or integrally part of modern trauma care. With respect to definitive surgical care, that of course is going to be different between me as, for example, a general surgeon, Dr. Crozier as a vascular surgeon, Dr. Balog as a orthopedic surgeon. This program is not designed to redefine our base specialty. We're not about teaching a general surgeon how to fix a pelvis or an orthopedic surgeon how to suture bowel. The definitive surgical care falls back to the primary surgical specialty. Where it does extend, however, is this area of collaboration and coordination of the trauma care to facilitate the surgical care in those fields outside our base specialty. So this is not about redefining our core competency as surgeons, but rather developing that collaboration. I focused here on what we clinically aim to do. Of course, the modern trauma surgeons got responsibilities beyond this, academic responsibilities, research responsibilities, hopefully leading on into active collaboration in programs such as this here today. So it emphasizes there's not just on the clinical, obviously it's more than that. The selection is fairly straightforward, and as said, trainees, this would be very familiar, a 3-stage application, CV, referee report, and interviews. A FRAX is a minimum entry into the program at the moment. At the moment, it is only the general surgical stream, but as I say, hopefully the vascular and orthopedic streams can be opened up momentarily. This year, everything, of course, has been disrupted with COVID, and we are actively considering a second intake, given the upheavals around the fellowship exam as well. If you're thinking of embarking on a subspecialization into trauma surgery, irrespective of which field you're coming from, general or vascular, or so forth, of course, some research and some previous experience in the field is going to be desirable in terms of obtaining marks in the structured CV and referee reports. I'm not going to get bogged down in the precise detail of the marking, but of course we can have any further offline discussions with anyone that's interested. The key components of the program come down to the clinical experience. It's a 2-year program with post-fellowship training at 2 clinical sites. in association with some significant research component. The first year looks roughly like this. This is lifted straight from the course manual. There are some in-training assessments. We would envisage a candidate having an appointment at an accredited hospital, either here or overseas. We are very much keen on collaborating with other sites internationally as well, not just Australia and New Zealand. The EMST stipulation on there is understood, and then the second year, a very similar clinical year. The research components involve publishing a paper and presenting somewhere. I hope this program is of interest to the people here today, and can I say what a fantastic meeting it is so far this morning. It's absolutely fantastic seeing so many interested people from across Australasia contributing in the field of trauma care. We very much set this program up to sit alongside the developments of trauma surgery. We've seen so many academic developments in trauma surgery. We've seen so many educational developments in trauma surgery. We've seen system developments, college organizational processes, and health advocacy. This is now a pathway that hopefully assists people interested in going down this to mentor them, to guide them, and to ensure that the necessary building blocks are there to functionally practice in surgical care. If you need further information, can I please refer you on to, first of all, the GSA website. As I said, the reason we've partnered up here with GSA was purely for functional and administrative reasons. GSA had previous experience in the transplant program, but the parent organization here is the Trauma Surgeons Association. You can see there the committee members of our training committee. I'm sure that any one of us would be more than happy to field questions directly. Otherwise, please get in touch with me directly as well. If there are any questions, give me a call, give me an email. Again, thank you very much for the opportunity to present here today. And have a pleasant morning. Thank you.
Dieter, thank you so much. And people,
if there's online questions, we've still got a few minutes, by all means.
Perfect, yeah, and I was going to say people should feel free to ask questions now in an open way of Dieter, but I'd gently invite people to refill cups of coffee or tea and to be back seated by in the next 2 minutes, please, ready to get underway at 11:26. I will just let people know too that there is a second break at 12:20, and Catherine Martin is back with us. Catherine is going to give a bit of an overview of Damian McMahon. That'll be quite a privileged opportunity for those of us able to listen to Kate's presentation.
Good morning, everyone, and thank you for attending the 2020 Damian McMahon Trauma Paper Competition. My name is Dr. Kate Martin, and I'm one of the Trauma Section conveners for the RAC's Annual Scientific Congress that was to be held in Melbourne in May of this year. I would like to share with you this morning some reflections on the professional life of Damian. Damian McMahon was the director of the Shock Trauma Service at Canberra Hospital from 1997 until 2012. He was an acute care and trauma surgeon, a retrieval clinician, an educator, and a tireless advocate for the injured. After training in general surgery at the Austin and Repatriation Hospital in Melbourne and obtaining his FRACS in 1993, he was appointed as the Trauma Service Coordinator at the Preston and Northcote Community Hospital, otherwise known as PAD to those of us from Melbourne. He then undertook a fellowship in traumatology and surgical critical care at the Hospital of the University of Pennsylvania in Philadelphia from 1994 to 1997. On his return to Australia, he was appointed as a staff specialist at the Canberra Hospital and soon after became the director of the Shock Trauma Service. Damian had a tenacious drive to improve the care of the injured, which was evidenced by his contribution to trauma systems across Australia. He lobbied to establish the Shock Trauma Service in Canberra and the South Care or Capital Region Helicopter Retrieval Service. He played a pivotal role in the development of the RACS Trauma Verification Program and was part of the foundation faculty that established VSTC in our region. He also instructed on EMST and CRISP, held an academic appointment with the Australian National University School of Clinical Medicine, and was the director of the Clinical Skills Centre at the Canberra Clinical School of the University of Sydney. Damian served on the RACS Trauma Committee as well as the RACS Verification Committee, which he chaired from 2001 to 2005. He was also an early committee member on the CRISP Committee. To great acclaim, Damian convened the inaugural ANZ Trauma Directors course held during the RACS Trauma Week back in 2003. It was through Damian's hard work, persistence and absolute belief that all injured patients deserve world-class surgical care that helped establish ANZIST, the Australian New Zealand Association for the Surgery of Trauma. He was the founding president, and through his leadership, the young association was recognised by the AAST, that is the American Association for the Surgery of Trauma, through acknowledgement as an associated society on the cover of the Journal of Trauma, and through the establishment of an ANZ free paper session at the annual meeting of the AAST held in Hawaii every 4 years. Above all of these professional achievements, Damian was an empathetic and optimistic soul who taught many of us to see the human side in all we do in medicine. To borrow the words of a colleague who knew him well, he made everyone give that bit more, try that little bit harder, and you'd be that bit better for it. He was a rare clinician whose dedication to his profession was solely based on the fact that he truly felt privileged to practice medicine. The Damian McMahon Research Travel Grant was established in 2014 to commemorate his life and to reward excellence in trauma research. The $3,000 prize money is awarded annually for the best trauma paper presented by a trainee at the RACS Annual Scientific Congress. It is a condition of accepting the prize that the trainee will use the funds to present at the ATLS Region 16 meeting in the same year. The winner of this competition is then invited to represent Region 16 at the American College of Surgeons Committee on Trauma Residence Paper Competition in March the following year. So on behalf of my co-convener, Professor Ben Thompson, and myself, I'd like to thank the junior staff here who have put in the time and effort to prepare their research projects for presentation. Damian was a very humble man. However, I think he would be rather chuffed at how this program has grown, particularly in recent times.
Now, forgive me, I just had I was thrown off the platform. I'll just gently invite Elizabeth Lockie. Elizabeth, if you'd be kind enough to unmute, prepare your video and share screen to talk to us now on poor compliance with obstetric trauma imaging guidelines.
All right, good morning everyone, and thank you for inviting me to present. My name is Elizabeth Lockie and I'm a General Surgical Registrar at the Royal Melbourne. And today I'll be presenting about a study we did around the compliance with obstetric trauma imaging guidelines. So we'll start off with a case. You're in the emergency department and a 32-year-old female who is 25 weeks pregnant comes in after a high-speed motor vehicle crash. The handover from the ambulance officers says that she has no allergies, is on a pregnancy supplement. It is her first pregnancy, which has been uncomplicated, and she has no other medical comorbidities. And she was the restrained driver in a car travelling 70 kilometres an hour when she lost control and rolled into a ditch, as you can see. Airbags were deployed, head strike, but no loss of consciousness, and she was assisted out of the vehicle. On primary survey, there are no significant findings with acceptable airway, breathing, circulation and GCS. And on secondary survey, other than a gravid abdomen, there are no significant findings. So what imaging would you order? A chest or pelvic x-ray, a CT brain, C-spine, a CT chest with or without aortogram, or a CT abdomen and pelvis? Well, as per the trauma guidelines, this patient should have all of these scans, i.e. she should be treated as if not pregnant. However, if you erred on the side of not ordering all of these scans, then you are not alone, and you are likely balancing between the what you believe is the fetal damage from radiation and the maternal risk due to missed injury. However, the key message in all obstetric trauma guidelines is that the mother must be treated first, and that initial treatment and imaging priorities in the pregnant trauma patient are as if she is not pregnant, because the risk to the fetus from missed maternal injury is far greater than the risk from any radiation. One of the reasons that is stipulated as to why clinicians are fearful of radiation is that they do not know the true risk. The background, these diagrams illustrate the background risk of childhood cancer, which is approximately 1 in 500, which with a CT trauma scan of a brain, cervical spine, chest, abdomen and pelvis, the risk of childhood cancer goes up to approximately 1 in 200, likely at its maximum, because there is quite a wide variation on this, depending on the type of scanner and also the gestation, with the greatest risk being during the first trimester. So the reason that we did our study was that there was a previous study at the Royal Melbourne Hospital in 2012 about the compliance with imaging guidelines in obstetric trauma. And they found that only 19% of patients presenting following high-risk mechanism trauma had complete imaging as per the guidelines. Following this study, there were numerous interventions to try and increase this, including education for surgical registrars and consultants, emergency doctors, increased engagement with the emergency department, and 2 Victorian trauma grand rounds which focused on obstetric trauma. So our study was a retrospective study of trauma patients who presented between 2015 to 2018 to the Royal Melbourne Hospital, which is a level 1 obstetric trauma centre being located adjacent to the Royal Women's Hospital. Out of the nearly 18,000 trauma patients, there were 420 who were pregnant, and after exclusion of those who declined imaging, delayed presentations and those with insufficient notes, there were 388 to analyse, with 124 presenting following high-risk mechanism, being motor vehicle crashes greater than or equal to 60 kilometres an hour, pedestrian versus car greater than or equal to 30 kilometres an hour, and a fall greater than or equal to 3 metres. So if our case had been part of this study, well, we found that following high-risk mechanism, only 14% of patients had complete imaging as per the guidelines, 66% had incomplete imaging, and nearly 20% of patients presenting following high-risk mechanism trauma had no imaging at all. The case would have been even less likely to have complete imaging, as motor vehicle crashes were least likely to have complete imaging at only 13%. We also looked at the compliance with different modalities over time and found that compliance with CT abdomen, pelvis and CT chest increased over time, while compliance with pelvic and chest x-rays decreased over time. This prompted us to think about the role of chest and pelvic x-rays in diagnosing injuries in hemodynamically stable patients, because of note, only 2 of our patients were hemodynamically unstable. We stipulated that perhaps clinicians are deciding on scans on a case-by-case basis and preferring cross-sectional imaging over plain films as a way to minimise radiation while also not missing maternal injuries. While our data could not support or refute this due to the fact we didn't collect information on missed injury, there are studies that have been done that look into this. Wisbeck et al. Published in 2006 in the Journal of Trauma about the role of chest x-ray in stable trauma patients. And they said that the role of chest x-ray should be relegated to that of cervical spine radiographs in the assessment of hemodynamically stable patients. They based this on the fact that out of the 487 patients who were stable with a normal chest examination, 29% had chest injuries on CT and only 10% had injuries on the x-ray. And the x-ray did not prompt any intervention in any of these patients. So while chest and pelvic radiographs are still a part of the trauma service guidelines and the ATLS guidelines, we wonder whether they do still have a role in the imaging and assessment of hemodynamically stable patients. Now, the limitations of this study are that it is a retrospective study, and the main issues of that being inconsistent documentation, particularly around the decisions around imaging from patients and clinicians, and also the loss to follow-up and therefore missed injuries from transfer to largely the Royal Women's Hospital or discharge home. And also, as I said, our population was largely hemodynamically stable, with only 2 being unstable. So in conclusion, compliance with imaging guidelines in obstetric trauma remains low. There is a trend towards CT and away from plain films, and the role of plain films may need to be reviewed in stable trauma patients and stable pregnant trauma patients. In the future, we are looking to compare the compliance with imaging guidelines in all trauma compared to obstetric trauma to see if obstetric trauma is an outlier, and to examine the role of plain films in all stable trauma patients, as the judicious use of imaging in all patients is important, but particularly in obstetrics. I would sincerely like to thank the Royal Melbourne Trauma Service, and particularly those who work on the trauma registry, and also mention that we have just had a letter published in Trauma around this same topic. Thanks.
Elizabeth, thank you for that important paper. And I'll ask Dieter.
Thank you, and I would really like to congratulate you and your colleague authors on tackling a important and ongoing controversial topic that does cause disproportionate anxiety level in the trauma bay on a regular basis. I have several questions and maybe 1 or 2 comments. The study compares the clinical practice with a given standard. Has that standard been validated, or where was that developed from?
Yeah, so the guideline we compared it to was the Royal Melbourne Hospital obstetric trauma guidelines, which is one in a range of guidelines which have been developed by the trauma service. And it was actually updated last year. So we did use the old guideline. However, it has been validated, and it was worked on by the radiography department, the trauma department, the emergency department, and also the radiation engineers.
Thank you for clarifying that, because understanding that baseline perhaps you can give us a bit more information about where this sits. How does it compare in terms of compliance with the guidelines for non-obstetric trauma? That's my second question, and perhaps a lead on. Is compliance equally problematic with non-obstetric trauma, and perhaps some insights into that? Beyond that, I just was curious a bit more to understand on what scanner protocols you have. As you're aware, the radiographers do have quite a degree of choice in how many phases, split bolus, multi-phases, and so forth. That obviously affects radiation dose as well. Again, thank you.
Thanks. So on your first point, the compliance with all trauma patients, we are interested in looking at that, and it's a question that has come out of this. So we're looking, we're putting together an ethics application to do that at the moment. I suspect that we will find again that compliance with chest and pelvic x-rays is quite low, whereas with CT it would be higher. Just because particularly in the stable patients, obviously in unstable patients, you always get a chest and pelvic x-ray, but in a stable patient who doesn't have any respiratory compromise, it's more likely that they go straight to the CT scanner. But yeah, we are certainly going to look into that. And on your second point, I didn't look too much into the specific protocols they use around minimising radiation to the mother as much as they can. However, I do know that when we notify they're pregnant, they do this. And particularly in terms of radiation doses, it's known that the greatest radiation doses will be from CT angiograms and other scans that use significant amount of contrast. So those are certainly used judiciously in pregnancy so that the radiation is minimised. But I don't know what specific protocols they do use in the pregnant traumas.
That's well answered and very, very well presented, Elizabeth, and an extremely important topic. I wondered if we can close that paper, and I'll invite Enoch Wong now to unmute and share screen. And Enoch's going to talk about the use of the Canadian C-spine rule in blunt trauma. Enoch.
Thank you to the organising committee for asking me to speak, and I'm talking today on how the use of the Canadian C-spine rule has reduced the number of cervical spine scans performed while overall maintaining its sensitivity. And this was a collaborative project between the Departments of Emergency Medicine, Surgery and Medical Imaging. I'd like to acknowledge the many others who have helped drive this project. So we know that clinically significant cervical spine injuries occur in 1 to 3% of stable blunt trauma patients, and failure to diagnose these can result in long-term consequences and irreversible damage. So various algorithms have been used to determine the need for imaging. So these include the Nexus and Canadian C-spine rule. CT is the gold standard in diagnosing neck injuries. However, there may be a lot of unnecessary scans being performed, and we can see this in the rates of scanning that have increased over time. For example, in our institution, in the emergency department, in 2014, there were 16,000 scans compared with about 51,000 attendances. But in 2018, there were almost 26,000 scans for about 70,000 attendances. And this represented an increase in attendances of 35%, but an increase in scanning rates of about 56%. And the number of scans actually doubled from 13,000 to 26,000 in an 8-year period. So clearly this is unsustainable. There are multiple benefits to reducing the need for imaging. So there are obviously patient benefits by reducing immobilization times and reducing radiation exposure. There's workload benefits, and this includes reducing the nursing burden in caring for colored patients and overall workflow. And obviously, one of the most important is that of cost. So the aim of the project was simply to introduce an evidence-based approach to cervical spine assessment and cervical collar application. Prior to the project, the ordering of imaging was not standardized and performed at clinician discretion. And the goals of the project were to provide clarity on decision-making using a validated tool, tried to reduce unnecessary CT imaging without missing clinically significant cervical spine injuries, and ultimately reduce the number of hours spent in a collar for patients. So this study was performed at our institution, Box Hill Hospital, a tertiary referral hospital in Eastern Metropolitan Melbourne, and we're considered a level 2 trauma service. So after some discussion, we implemented the Canadian C-spine rule, which is a validated rule published in the early 2000s, which has subsequently gained widespread use. It's a 3-step decision rule to determine the need for cervical spine imaging, and is essentially applicable to the blunt, stable trauma patient. This is a flow diagram, which I am sure many of you are familiar with, so I won't go through it in great detail for the sake of time. This project was approved as a quality assurance project and was performed over the study period of February 2019 to February 2020. An audit form was introduced based on the Canadian C-spine rule and can be seen on the right of screen. And importantly, we actually incorporate the rule for patients over the age of 65 years old, rather than send them straight for imaging, which is what the true rule would have mandated. So this audit form was implemented for all patients with a suspected cervical spine injury. So that is essentially anybody who was collared. And the forms and patient notes were reviewed weekly by auditors who followed things up. So 1,027 patients were assessed in the 12-month period, and 103 patients were excluded as they were not trauma patients, leaving just over 900 patients for analysis. The patients were classified into 3 groups. So yes, those that met the Canadian C-spine rule and required imaging. No, those that could be clinically cleared without the need for imaging, and those that in which the rule was not applicable. And generally this was where assessment was not appropriate via the Canadian C-spine rule, so that is unstable patients or patients with altered GCS. And overall, there was no significant differences between the basic demographics between the groups, with the average age being 63 years and quite similar male to female ratios. So this graph demonstrates the main mechanisms of injury, and as you can see, mostly there were falls and motor vehicle and motorbike accidents, which is to be expected. There was no significant difference between the groups. These are the results for how many patients underwent CT neck imaging, and overall 65% of patients had some form of neck imaging during the study period. And obviously there's a significant difference in patients that met the Canadian C-spine rule, required imaging, and those that didn't actually require imaging. So in fact, 105 patients could have been cleared clinically according to the Canadian C-spine rule, but still got imaging. And this rule was obviously retrospectively applied, and a lot of the patients had dangerous mechanisms ticked on the audit form, but on review of the notes, probably didn't meet the criteria for this. Importantly, out of these 105 patients, none of these patients had cervical spine injuries, so there's definitely room to reduce the number of scans further. All but one of the 319 patients in the no imaging criteria were cleared clinically via the Canadian C-spine rule. I'll discuss that one patient in the next slide. And I'll also highlight the fact that there were 2 patients, according to the audit tool, that didn't have imaging that probably should have had imaging initially. One of these patients did have a cervical spine imaging injury diagnosed slightly later whilst as an inpatient, but on review, both of these patients probably more appropriately fit the not applicable criteria. So this slide demonstrates the patients with a cervical spine injury we detected during the study period, broken down into each criteria group. Overall, there were 46 patients with some form of cervical spine injury detected, and mostly this was in the group that were supposed to undergo imaging in the yes column. However, as you can see, there was one patient that was clinically cleared that represented a few days later and was found to have a cervical spine injury. And according to the audit tool on this patient, they met all the criteria for clearance, including no neck pain. And so this patient certainly does count as a miss, and after review, there appeared to be some language barriers making initial assessment a bit challenging. Overall, the average age of the patients having a cervical spine injury was close to the average age of our cohort, but there were more male patients with injuries. So overall, this gives the application of the rule in our cohort a sensitivity of over 97%, with essentially one miss that I just described, and the specificity is similar to the original published article of about 50%. But how has the rule, implementation of the rule affected our scanning rates? The audit captured how many cervical spine scans were being performed, and in this graph on the x-axis is the number of weeks since the audit implementation. So in the first 6 months, you can see overall scanning rates are decreasing from about 15 to 20 per week to 10 to 15. And at the end of 2019, we collected the number of CT cervical spine scans performed in the emergency department and compared it to the same time period of 2018. So you can see that in the yellow bars, there's a reduction of about 300 scans. And over the course of the year, this has essentially resulted in an over 30% decrease in the number of cervical spine scans being performed in the year. The blue graph are those numbers extrapolated over the course of a 12-month period. And of course, there are multiple variables affecting scanning rates. But overall, what this demonstrates, we believe, is simply prompting clinicians to rationalise the need for CT cervical spine imaging by using an evidence-based tool. So in conclusion, we analysed over 900 patients with suspected cervical spine injuries in a 12-month period using our audit tool. With the use of the Canadian C-spine rule, we were able to detect all but one of the cervical spine injuries over the entire year, giving an overall sensitivity of 97.4% with an overall injury rate of about 5%. We found a further 105 patients that should have been cleared clinically by the use of the Canadian C-spine rule but underwent imaging regardless. And importantly, we were able to reduce the number of scans performed by over 30%. So using the Canadian C-spine rule appears to be safe and effective with potential significant benefits to throughput, flow and cost by rationalising the use of CT cervical spine imaging. Thank you.
I'm grateful, Enoch. A very comprehensive presentation, very relevant to many trauma centres and well presented. With a question from observers, what was the cost saving in consequence of implementing the protocol, do you think?
We are going to do some further analysis into this. I don't know the exact cost saving of how much a CT scan would cost, but there's obviously cost savings from a benefit of reducing the number of scans, but also reducing perhaps the time that the patient spends in the department if they can be clinically cleared whilst waiting for scans. We haven't really looked into that further, but that's certainly something that we can look into.
And just a point of further elaboration, the patient that arrives from the field with a collar, what steps do you take then as you manage that patient, making the assessment through the Canadian C-spine rule?
Yeah, so the collar was about 50% of the time. The collar was actually applied prior to presentation, so by the Ambulance Victoria that brought the patients, and about 50% of the time the collars are actually applied in the department. So perhaps they were either retrospectively applied or the patients walked into hospital and then had a collar applied. And in terms of how we go about assessing these patients, well, the initial assessment is based on the doctor that goes there, but when they go to try and either clear the cervical spine or go ahead and perform the cervical spine imaging, that audit tool has to be filled out in the first instance. So it would prompt the clinician, hopefully, to think about whether the patient actually needs scanning or can otherwise be clinically cleared. So it's really a prompting tool to help clinicians use evidence-based in their practice.
Well done, and I do commend you for the Christmas, the professionalism of the presentation, Enoch.
Thank you.
I wondered if I can call now Wen-Shen Lee, who's going to address us on ocular trauma.
Hello, can you hear me?
Loud and clear.
Okay, just one sec, just sharing my screen. Just one sec. Oh, goodness. Sorry, I was at work, so it was...
No, that's all right. Don't panic. Just take your time. Okay, I wondered, Angelica, if you just unmute.
Mm-hmm.
Yes.
And we might throw to you. And Wen-Shen, if you just sort out your...
Okay.
But that's quite all right. Angelica, if you just be kind enough to come forward now.
Thank you. Good morning, everyone. Thank you for spending this time on a Saturday morning and this opportunity to share our data on CT imaging and hanging injury. The actor Robin Williams, the beauty of Kakadu National Park, they are worlds away. However, there is an uncomfortable truth that is common link between the two. It's that the rate of suicide by hanging, which is the key in our presentation today. Australia, as you can see on the international stage, it is in orange, which is in the second highest tier of the suicide rate per 100,000 population. It means there's about 8 suicides per day in Australia alone. And the rate of suicide is double in Indigenous and Torres Strait Islander patients compared to non-Indigenous patients. In terms of the mechanism of suicide, hanging is there number 2 in terms of the frequency. Yet we are uncomfortable talking about it in the trauma bay as well as in the trauma literature. We have mechanisms, protocol, and great understanding of mechanisms of injury from things like poisoning, car accident, high falls, even stabbing, but not much is studied in the terms of hanging itself. Often we relegate to CT imaging to maybe cover up for our lack of knowledge in this area for injury assessment. Therefore, in the literature recently, there's been questions raised about the overuse of CT imaging. The aim of our study is to assess the frequency of use of CT in these patients and the actual injuries outcomes detected by the CT and the overall mortality rate. This is a 10-year retrospective cohort analysis of 407 patients with hanging injury presented to Royal Darwin Hospital. Compared to the literature, there's about 160 is the largest series. So this is by far the largest number of patients from one center having CT imagings post-hanging injuries. After obtaining the Human Research Ethics Committee approval, we look at our data from the trauma registry, about 90 patients, in which demographics, ISS and HDU ICU admissions were collected. We expanded our search to the medical record patients. These are the patients who presented post-hanging, however, does not require hospital acute admission. Then we looked at the use of the CT, in particular brain, C-spine, and CTA of the neck. And we looked at the outcomes in terms of hypoxic injury, C-spine injury, and neck vessel injury, as well as their mortality. In terms of demographics, not surprising, mainly in younger male, 54% presented with very poor GCS, and up to about 60% require high dependency unit admission. We use CT imaging quite frequently, CT brain up to 77%, now almost 20% for CT C-spine, and 60% for CTA neck. What we found that was interesting is that hypoxic brain injury expected 17%, yet there was 0 cervical spine injury in our patient population. And we found only 3 neck vessels injury out of so many CT scans being performed. These 3 patients, the first one is a patient who presented with a GCS 15, was found to have later carotid artery dissection and stroke and ended up with GCS 10 and died. The second patient had a carotid artery spasm, which was then confirmed on ultrasound not to have a carotid dissection. It changed management in the third patient, in which the patient had a carotid artery dissection despite being neurologically intact, and was started on antiplatelet therapy and was able to go home without sequelae of stroke. Our total mortality rate is 26%. So on the left side column, we look at the acute admissions compared to all the patients' populations that came in. In patients requiring acute admissions, we scanned them more often, and of course, we detected more high injury detection rate. However, this probably reflects the severity of the injury in the first place. In summary, suicide attempt by hanging, predominantly younger male with moderate severe GCS, up to 60% require HDU ICU admission with up to almost a quarter of mortality rate. But how to interpret this data about the frequent use of CT brain, CT C-spine, and CTA neck, yet seemingly low yield of their injury detection? I think we need to step back on how to interpret this data. We need to differentiate what is judicial hanging, which is long rope hanging, in which we describe dying from, the classic hangman's fracture with cervical spine injury. That is completely different mechanism of injury to suicide hanging, which is shorter rope that is often being used, and patients die from asphyxia and cerebral hypoxia, not from cervical spine injury, because the force generated is not adequate. Therefore, CT brain can be justified with a detection rate of 17%. However, that begs the questions for patients who are neurologically intact with GCS 15, do we still need to scan them to exclude hypoxic brain injury? CTC spine, we use them 0% cervical spine fracture. However, the key is the CTA of the neck injury. Even though the yield is low, 5%, however, the potential for therapeutic options such as the antiplatelet therapy can change outcomes. So we believe that this should remain in the guideline. How does this study change our clinical practice? On two different levels. First, as individual clinician, I think most of us who have come to a trauma call saying it's post-hanging, there is this fear of an unknown and an emotional factor associated with it. Slightly different from the way we get called for trauma call for car accident, for example. First, as trauma clinicians, we put our hand up to look after patients at the most vulnerable state of their life, at the darkest state. So instead of fear and shame going into talking to patients post-hanging, maybe we should replace that with a bit of compassion and warmth. And our fear of not knowing the mechanism of injury, instead of putting that way and just, CT brain, CT C-spine, CTA neck, everyone, maybe we should replace that with a better understanding of trauma. Trauma is the study of mechanism of injury. The way we ask our car accident patients whether there was airbags, seat belt, speed, maybe you should ask the same question with hanging patients about when were they found, how high was the tree or what was actually used, whether there were signs of asphyxiation, whether there were signs of venous congestions, etc. And I hope this small local study inspires bigger pictures in terms of clinical studies on suicide and hanging in general. Thank you.
Angelica, thank you. Very important statements and an impassioned presentation. Deirdre, I wonder, do you?
Yes, thank you. Thank you for a very nice presentation on a very tragic and sadly all too frequent encountered injury mechanism in our clinical practices. Several questions and comments. Firstly, I was actually surprised at the overall low rate of CT brain, as quite a few of these patients also have a psychiatric indication for a CT brain. But of course, there may be a pre-existing disease, and from that nature, they may have already been scanned. So it would be interesting to know a bit more about who's gone into this study. Is it just who actually needed to be admitted to the hospital, and what was the admission threshold? A second comment, thank you for addressing this in your discussion already, the differences between a judicial and domestic hanging. There's quite some work out there from a Canadian forensic pathologist on that topic, and really gets at the difference between the cardiogenic and the neurogenic shock mechanisms that these patients have. The low C-spine fracture rate, in other words, is not unexpected in the domestic setting, but on occasion is still found, and then can obviously be highly relevant. Similarly, ligamentous injuries. A final point or question, that to the best of your knowledge, were there any missed injuries, in particular the vascular injuries? Obviously, there's a considerable morbidity and mortality attached to missing a carotid or vertebral artery injury. Thank you for the very nice presentation.
Thank you for your comments. The patients that had the CT brain as the first presentation from a psychiatric triggered suicide and hanging, yes, one could argue to detect organic pathology. However, these are young patients with mean age but in the 30s. Some of them have repeated presentation. So one could argue if they've already had a CT brain in the initial attempt, maybe we don't need to repeat those CT brains after each hanging presentations. Secondly, in terms of the trauma registry admission criteria, in particular in this specific 90 most severely injured patients, they either have a trauma call or trauma alert, intensive care admission, die in hospital, or injury severity score more than 9. So that is the patient that we probably should concentrate our imaging from, rather than the general populations, I guess the general 300 others who came in neurologically intact. That doesn't require hospital admission. Missed injury, I guess, drives the higher rate of imaging. However, we found that the patient with hypoxic brain injuries, all of them have poor GCS at presentations. Only one patient that had GCS 15 deteriorated to 10 within a short period that was captured to have a carotid dissection and stroke. So perhaps we can use more of our clinical judgment and observation and to detect injuries in that way, rather than having a blanket rule to scan everyone that come in even though they're neurologically intact. Yes, CTA needs to be used because of the mechanism of injury with the occlusion of the carotid and the jugular veins. Yes, it is technically 5%, but low yield. However, the potential for therapy there is high. So yes, that should probably remain in our normal practice.
Just a quick question, if I could, Angelica. Do you know how many of these were incarcerated?
We did not look specifically for that particular questions, but yes, we can look into our data, in particular the medical record patient, the 300, probably some of them would be from incarcerated in prison.
Okay, Angelica, a very, very important topic, and there's a lot of learning there, well presented. Thank you. I wondered, Wen-Shen, are you able now to address us?
Hello, can you guys see my slide? No.
Yes.
Works better?
Yes.
Okay. All right, thank you everyone. Good afternoon, my name's Wen. I'm one of the surgical residents at the Alfred, and this is a topic that's not very commonly discussed. So just as a start, I've got no relationships to disclose. So as a background, we know that falls are a very common problem in older people worldwide, Australia as well, and there is quite a lot of morbidity and mortality associated with such. Less prominent perhaps is ocular trauma, but the statistics are quite significant, with a fair number of Victorians and people worldwide having a high incidence of ocular trauma to themselves, and with quite a significant burden on the healthcare system. But what about ocular trauma from falls in the elderly? This is a topic that's not very well covered in the literature. We do know that falls account for about 30% of admissions related to ocular injury. However, we don't know a lot of things. We know that falls have a very poor outcome with regards to head injuries and long bone injuries as well. But regarding eye injuries, we don't really know. There's a number of studies in the literature documenting certain aspects of ocular trauma in the elderly, but none addressing this question specifically. So what did we aim to do with our study? First, we wanted to see whether ocular trauma from falls in the elderly were increasing or decreasing as time goes by. What kind of injuries do the elderly sustain when they fall and injure their eyes? Whether or not these injuries are picked up on time, and if they are delayed, what factors contribute to it? And lastly, what kind of outcomes do they have? How did we go about this? We looked through our ophthalmology service audit over the last 10 years and looked for all patients over the age of 65 with a fall and who were referred to our service. And we looked through documentation as well as the audit to make sure that things were as accurate as possible. So things that we assessed were, of course, baseline demographics, how long they took from presentation to ophthalmology referral. In order to maximize accuracy, we looked at all documentation possible, and what kind of injuries they sustained and whether they needed ICU admission. Regarding outcomes, we looked at the best corrected pinhole visual acuity at baseline and at 3 months. So blindness was defined as a best corrected VA less than 660. Regarding injury categories, these were classified as major injuries. We also had minor injuries with minimal clinical consequence, and under the category of other, we had these injuries that were seen maybe once or twice. So what did we find in our study? So from this table, I've got the summary points. First of all, there was a year-on-year increase in terms of the numbers as a general increasing trend, but as a summary, so 270 patients, majority required admission, more females than males, an ICU admission rate of 8%, 12% of patients could not have their visual acuity assessed on presentation. I'll talk about that in a bit. A final blindness rate of more than 10%, and an almost 6% inpatient mortality rate. So what were the reasons for referral? The most common reason for referral was a routine review for an orbital fracture. Of note, only about 6% of referrals were from a delayed diagnosis or from a tertiary survey finding. Regarding the injuries sustained, from this table you can see that these are the summary points. The most common reason for referral was an orbital fracture, 189, most common injury. The most common injury leading to blindness, unsurprisingly, was that of open globe injuries, whereas most deaths occurred in patients with orbital fractures, and this was presumably secondary to intracranial injuries. Regarding delayed detection of injuries, most were minor injuries. About half were from a tertiary survey, and about the other half came from other reasons, such as patients saying that they had a scratchy feeling in their eye or couldn't see properly. Of note, 11 of these patients were delirious or intubated. And one patient was a globe rupture. I'll talk about that in a while. So regarding patients with a non-accessible visual acuity on presentation, 34 of these, more than a quarter had a major sight-threatening injury, such as a retinal detachment or an open globe injury, of which 6 required emergency intervention, and 4 ended up blind, including one patient who had a globe rupture that was missed for 14 days because they were intubated. So what does all this data have, and what implications does it have for us? So firstly, with regards to clinical outcomes, of note, almost all of the major sight-threatening injuries were identified and managed in an expedient manner within 24 hours. However, despite all this, more than 10% of patients were permanently blind, and almost 6% of patients died during their in-hospital stay. And I suppose what we can conclude from this is the presence of an ocular injury from fall in an elderly person can herald a poor prognosis. And I think trauma practitioners should be aware of this statistic. Regarding patients who have a suspected injury who could not be adequately assessed, that constitutes quite a fair number who were referred, and the main reasons being delirium and intubation. note the high number of patients with a serious injury. And so in such a patient group, there should be a low threshold for referral, but other modalities of examination can be utilized, such as checking pupillary reflexes and looking at their intraocular pressure. And of note, 3 of 11 patients who required canthelysis for a retrobulbar hematoma who had their intervention done based on these findings. So, quick section on orbital fractures being the main cause of our referrals. Quite a significant proportion had an associated sight-threatening injury, of which a fair number, as we can see here, had a preserved visual acuity or one that was not accessible. So we therefore recommend that in the presence of an orbital fracture should warrant an ophthalmology assessment. With regards to missed injuries, we can see that most of them were minor, but there were some major injuries that were missed. The reason why this number was so small was because our center utilizes secondary and tertiary trauma surveys for all patients so that missed injuries are kept to a minimum. So what were the strengths of our study? Firstly, I don't think we've seen a previous study documenting specific ocular injuries in elderly patients with falls and their outcomes. And this study highlights the significant mortality and morbidity associated with ocular injuries in patients with falls. And I think all trauma practitioners should be aware of these numbers. Limitations-wise, our study relies on how accurate written documentation was and how accurately the audit was maintained. So there may have been patients who were missed or not recorded down. The other thing was some things, especially in older paper-based medical records, could not be adequately assessed, and there might be some things that really depended on how accurately these things were documented in the past. So with regards to directions for the future, I suppose the main thing that I can think of would be what are the long-term outcomes of these patients? How do they do well functionally, and what kind of long-term mortality rates they have? And that is it. Thank you very much for listening.
Wen-Shen, thank you. I wonder if Jeremy, you might have any questions for Wen-Shen.
Yeah, Wen, thank you for that presentation. It's often sort of not necessarily ignored, but like it's sort of pushed aside, like in terms of the eye trauma, because we're too busy trying to manage like the bleeding everywhere. But it is quite important, and I guess there's a couple of questions, and you did mention in your last point about, which I'm really pleased about the long-term outcomes, because I guess we don't really know what the impact is, right? And like of this eye trauma, particularly in the elderly. I just wonder, first of all, do you have, or did you look in the data about the discharge destination for these patients, as in, you know, maybe if you knew, like as in that a lot of the patients who had significant eye injuries or maybe even minor eye injuries went from home originally prior to their injury, then had to go to a prolonged period of rehab or nursing home, you know, that's quite significant, and that then adds weight. And then the follow-up, I guess, to that is really, what are your thoughts? I'd be interested in your thoughts in terms of how do we prevent this from happening? You know, should we be recommending things like, I don't know, eye protection over a certain age? I don't know. I mean, I'd be interested to hear your thoughts about what we can do about it, because it doesn't seem like the delay is a big problem in a level 1 trauma center. We pick up the injuries, it seems like, from your data. So what can we do to improve the care of these patients? So they're the 2 points.
Thank you for your questions, Jeremy. Yeah, these are good questions indeed, because looking at the mechanism of injury of these patients, we've had patients of all sorts of injury mechanisms, you know, like a lot of them happened, you know, middle of night, getting up, going to the bathroom, they slip, their eye hits the corner of the table and they get a globe rupture. I'm not sure how how we prevent that, you know. It's quite tricky really, because aside from, you know, having them get more assistance to go to the bathroom, but no one really anticipates these things happening, I think. You know, we've got a fair number of injuries from people walking their dogs, going for walks outside, and you know, they fall and hit their head. It is. And if we looked at the data earlier on, a lot of these patients fell in their home environments, for example. So maybe we could make the homes a bit safer. I'm not, good questions. I'm not very sure on what the best way to minimize such a risk is, and whether or not eye protection is a step too far, you know? Yeah. And your other question was the discharge destination. Unfortunately, no, I was the one person looking through 10 years of data. I think it was quite a task looking at their disposition and their visual outcomes and chasing all that documentation down. Looking at the old paper-based medical records, it was really hard to see where on earth they landed up after they got discharged. So yeah, I think it would be really nice if a study could be conducted in the future looking at long-term outcomes. I think we'd have a much better idea by then.
Well done, Wen-Shen. And on behalf of us all, I'm very, very grateful to the breadth of presentations that we've been privileged to hear. What I'll do now, the attendees and participants, there'll be a presentation by Kate Martin on Damian McMahon. While that's running, I'd invite the judges to step off this platform onto Teams. We'll be back in 10 minutes time. So at 12:40, and that's 10 minutes after the advertised time, we'll be back for the presentation. Thank you. Before we close and announce the winner, I want to particularly commend Kate Martin for coordinating this event, and Catherine Walsh for the skills demonstrated in bringing together the opportunity. There's been a unanimous decision by the judging panel that the presentation most worthy of the awarding of the Damian McMahon Trauma Prize for 2020 should go to Enoch Wong for his presentation on the use of the Canadian C-spine rule in blunt trauma. The quality of the presentation and that work and its application in a range of contemporary trauma practice rendered it at a level where it was deemed most meritorious and worthy of the prize. Might I say, many of the other presentations were close, and it is always difficult with these forms of adjudication to single out a single individual. But on behalf of us all, Wen-Shen, know that you go with the grace of the Trauma Committee and the full support in the presentation now to the Chapter 16 meeting later on this year, and the opportunity there to present in America in 2021. I would, as we close, want to pay particular commendation to Angelica's presentation from the Northern Territory. That does give us pause for consideration, Angelica. Equally, though, praise could go to all of those that have presented today. So, on behalf of us all, and with special notes of acknowledgement to Catherine Walsh, to Lin Zhenou, and to Ali Chen, I do thank you all for participation and wish you well, particularly in this brave new COVID world. I think the adversity that has been overcome to achieve the quality of presentation today is worthy acknowledgement again of the spirit of Damian McMahon, for which this presentation has been named. So again, everyone, thank you so much. Bye for now.